This is going to be topic 46, orthopedic trauma.
Overview. Orthopedics are the study of musculoskeletal system injuries, bones, joints, ligaments, tendons, and muscles. Orthopedic injury is a result from physical injury to the body, blunt or penetrating, caused by violent forces. Many of these forces are internal. Proper assessment and treatment requires knowledge of kinesiology, the study of human movement, biomechanics, as well as the application of mechanical principles to the human body. Chief concern: mechanism of injuries. The sprains, strains, fractures, and dislocations are all different, but they share the presence of pain. Paramedics have a comprehensive musculoskeletal injury knowledge. Biomechanics: the study of forces that muscles exert on the skeleton. And this would be any force, whether it be tensile force or pulling, tension force, compression or pushing, shearing, bending or torsion, twisting, applied to the muscles or skeleton will displace the tissue and thereby impact remodeling or reparative features of the bone. Degree of displacement is a function of the tissue's flexibility. Sprains and strains. We have all kinds here. Tendons or connective tissue. These connect muscles to bones. Strains is an injury to the tendon causing tearing, swelling, twisting, or pulling of the muscle. Sprain, injury to the ligaments. This is connecting bone to bone. Tends to make a joint unstable. Defined in degrees according to the severity. So a first degree injury, you get a little bit of tearing with swelling and pain, but a stable joint. A second degree injury, moderate instability, severe pain and swelling. And a third degree injury, ligaments completely ruptured, the joint is unstable, severe pain and swelling. On a fourth degree injury, and this is in your book, it's an avulsion of the bone. So essentially whenever the tendon pulled off, it pulled off a little section of bone with it. And then everything seen in the third degree sprain. Sprains and strains include a sprained shoulder, and this is most likely to be injured because it has very little stability in certain positions. So as you move it, it'll be loose in certain positions, and this can lead to bursitis, tendonitis, and even a frozen shoulder. Sprained thumb, force applied laterally, twisted knee. All the ligaments are at wrist, but the anterior cruciate ligament is the one that's most likely injured. Twisted ankle commonly and typically consists of a combination of ligamentous sprains and soft tissue injury to the ankle. High ankle sprain form an inversion injury to the ligament which attaches the tibia and fibula together. A midfoot sprain applies forces along the 5 tarsal metatarsal joints and the ligaments. All painful. Ruptures. Tendon rupture. Tendons are tough, fibrous connective tissue, sustain forces many times the body weight, but it can provide a breaking point and result in a rupture of the tendon. Types of ruptures are bicep tendon ruptures, quadricep tendon ruptures, patellar tendon ruptures, holds the patella on, Achilles tendon ruptures. This is generally due to direct trauma to the Achilles tendon. Dislocations. A dislocation is a complete movement of the bone out of the joint. Subluxation is a type of this, which is misalignment of the bones in a joint that results in the joint's instability. You can even have a subluxation in your cervical spine. Types of dislocation: dislocated shoulders, elbow dislocations, nursemaid's elbows. This generally occurs in children from or form of radial subluxation with a tear to the annular ligament. Hip dislocation, most often due to direct trauma. Patellar dislocation can be either acute, result from trauma, or chronic. People all the time go around and their patella will just kind of dislocate. Knee dislocation occurs with the displacement of the tibia and femur. And then an ankle dislocation. Dislocation of any one of 57 articulations. Fractures. Classification of fractures. It can either be direct or indirect. Direct would be small force applies to a localized area, or indirect is application of tensile force over the whole bone. Degree of type, high energy versus low energy mechanisms. It can be closed or open. A closed fracture, bone remains within the limb. An open fracture, the skin has been breached. A complete fracture is a displaced fracture, so the bone has come apart. Or an incomplete would be an example of an example of this would be a green stick fracture. And these come in types as well. A type 1 fracture is a wound on the bone less than a centimeter. A type 2, a wound greater than 1 centimeter. Or a type 3, extensive devitalization of the surrounding muscle and tissue and widespread wounds. Fractures, causes, and types. And then I have some x-rays in this section to kind of show you all whenever we talk about fractures and type. But osteoporosis can cause fractures due to inadequate amounts of calcium, vitamin D, or parathyroid hormones. Pediatric fractures. Growth plate fractures can disrupt the bone, and they're in types. They're called Salter-Harris fractures. Fractures of the upper extremities, and here's where we're going to start kind of looking at them. First of all, we're going to take a look at a humeral fracture. And as we can see here, the head of the humerus is fractured right there. An ulnar fracture, and this is the thumb side. So the radius would be here, and ulna would be here. Ulnar fractures associated with a dislocation of the radio-ulnar joint, also called a Montega's fracture. Fractures still continue here. This is a radial fracture. Thumb right there. Radius. These are generally, you'll notice, this one here is displaced a little bit. This is a wrist fracture. And I'll notice this area right here. When we see peak viewing through the bone, it means there's a fracture or there's a loss in density in the bone. Carpal fracture. So the arrow is pointing to it. So you can see this a little easier. There's the fracture. Hamate fracture. This is the small finger and the ring finger area. And this would be our fracture right here. Very painful hand. Not a lot of hand movement after you've had this type of fracture. This is a hand injury, and if you'll notice, there's multiple fractures in the hands. This is inside of a pneumatic splint as well. Fracture, probably a dislocation. And this looks like there might be fractures. We would need to see the lateral. So we could see if that small finger was fractured or not. Thumb injury. This is a dislocation. It should be going right there. But since it's pulled off of that joint, kind of riding back, grinding bone against bone, a lot of pain will occur in this. And a mallet's fracture. Now this is just to the distal end of the finger, generally does damage to the ligaments and tendons that hold this. They'll have to generally go in and fix this again. There's probably little bone fractures here and here, but the bone itself is displaced and pressed downward. Okay, causes and types continue. And I have pictures of these as well. Fractures of the lower extremities. This is a pelvis fracture. We'll see here. This is angulated. This is a pretty significant pelvis fracture. fracture, which is the neck of the hip, the neck of the femur, proximal neck of the femur. You'll see this is all disangulated and broken. Femur fracture. This one caused some pretty good displacement. There's bone fragments. One thing to note in this area, it's highly vascular because our vessels are running right down the inside of this. So in these bone fragments, lacerate those vessels, and very simply, you could bleed to death in that compartment or have severe hypovolemic signs and symptoms. Knee fracture. A lot of trauma did this. Fracture's right there, and I'll clear it off so you can take a look at the actual x-ray. Looks like it's also broken here. A lot of force come down on the knee, and it is displaced. Stress fractures. Make note to this little area right here, the little squiggliness, little white squiggliness of the bone. Is a stress fracture. Lots and lots of tension and continuous use and overabuse of the joint. Striking the heels in this case would probably have caused a stress fracture seen on the x-ray. Ankle fracture. This will be lots of pain and swelling to this area. Right here. Looks a little displaced. Probably involves some tendons and ligaments as well. And lots of soft tissue swelling will occur in this area. And a calcaneus fracture. This is your heel. So this, maybe even here as well. That probably will require surgical repair. All right, so history. Assessing a traumatized patient, the mechanism of injury and kinetomatics. Body mechanics, what line of force do you think that occurred? Would there be a linear line, a blow to the limb, point specific like a gunshot wound? Traction results in distraction of the joints and ligaments, and then compression results in impaction of the actual bones that are in there. Torsion results in a shear injury. History of pain, get an OPQRST, onset, provokes, quality, radiate, severity, and time. We may also get delayed pain as well, and this would be suggestive of inflammation or immediate suggestive of a fracture or rupture. And then any other associated symptoms that we have with this. Numbness, inability to feel distal extremities, things like that. Past medical history. Start with the sample, start with the allergies, and end with events. Obtain a standard past medical history, focus on any diseases that might impact bone health, history of previous injury, and last time of the injury actually occurred, so we know how long, especially if you have something like an asphyxiated limb, we're going to need a time frame on when the blood supply was cut to the distal tissues, and then any events preceding the injury. Fracture risk. A key to assessing fracture risk is the degree of osteoporosis that the patient has. Bone mineral density, reported as a T-score. 1 or greater is normal or low risk. 2.4 to 1 osteopenia, they have a moderate risk. And less than 2.5, they have osteoporosis or a greater risk. Medications prescribed also as an indicator if they're taking calcium supplements and things like this. Examination, start from the doorway, get a global impression and the signs of distress. Patient stance, guarded or unguarded, and the affected limb position. Compare limb symmetry. Primary concern is going to be neurovascular compromise. Perform a careful assessment for distal neurovascular function, utilizing knowledge of innervations and circulation. So if they are numb in that specific area, you need to figure out why they are numb. Be sure that they have an associated pulse in that area. On assessment, suspected sprains, dislocations, or fractures, assume the worst, assume it's a fracture, and treat accordingly. Disorders a paramedic must address in this are going to be pain, any kind of distal neurovascular compromise, and blood loss from soft tissue damage. And this can be substantial, especially if it's in a vascular area, say the femur. On treatment, fracture management clinical objectives are going to be pain management, prevent further injury, and the control of hemorrhage. In EMS, we essentially consider musculoskeletal injuries are assumed to be fractures until proven otherwise. This is various types of reductions. Look over them in your book. Preparation, obtain immediate manual stabilization, assess for distal neurovascular function, and consider analgesia. Now, generally, paramedics in the field are not going to reduce a fracture, but there are shoulder reductions that can be performed by traction or leverage, elbow reduction, Parvin method or forward force, finger reduction, traction and splinting, knee reduction, longitudinal traction, patella reduction, length is generally raised to flex the quadriceps, done with the patient sitting on a stretcher's edge, hip reduction, Bigelow method or Simpson maneuver. And very simply, we will not be doing this in the back of the ambulance. Our goal should be decrease further injury, assess and treat for pain management, and get them to the appropriate facility. In splinting, splints prevents pain as well as further injury. Mnemonics on this is going to be a fax mnemonic. It helps with function. We should check for arterial pulses, capillary refill, temperature, and sensation. Always whenever it's in the splint. Types of splinting are going to be twofold, upper and lower extremity. On evaluation, we should always keep in the back of our mind compartment syndrome, often associated with an extremity injury. Some similarities to a crush injury. And very simply, cross-section of the compartments of the lower leg, they could bleed in any one of these sections and apply pressure, thereby cutting off blood supply. The pathophysiology of compartment syndrome: pressure builds up inside a compartment. The compressive external forces, they obstruct venous outflow, forces decreased tissue perfusion, and leads to cellular hypoxia and ischemia, and eventually death unless we get cellular death of the area, unless we get ahead of the physiology. This is Table 7.2, causes of compartment syndrome. Obstruction and outflow leading to an increased compartment pressure, fractures, gunshot wounds, and stab wounds, snake bites, overuse, weightlifting, minor trauma and hemorrhage with anticoagulants, hemophilia. Compressive external forces leading to smaller compartments, splints and dressing, circumferential burns, the application of military anti-shock garments or pneumatic anti-shock garments, and crush injury, things like coma, narcotic overdose, and stroke. Disposition for orthopedic injuries: most are transported to community hospitals for treatment and rehabilitation. A multi-trauma victim should be transported to the trauma center. Life-threatening injury treatment, because it's going to be, the more fractures you have, the more you have a propensity to have further injuries and bleeding in those compartments. Suspected compartment syndrome: consult medical control and consider the use of hyperbaric oxygen or taking them to a facility that would have hyperbaric oxygen. In conclusion, orthopedic injuries, an everyday occurrence, potential to cause lifelong disabilities if not treated appropriately. Proper assessment and treatment, the first step to a full recovery, and the possibility of the return of full function.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith. SmithR at SamaritanEMSOK.com or 405-492-8243. Thank you.